Paul, I got a new pair of gloves today, but they're both lefts.
Go on.
Which on the one hand is great, but on the other one, it's just not right.
All right, I would have come close, I think, if you give me the time to process.
What are you going to do?
The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity, aside from possibly Cash Like Memorial Hospital and its affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Welcome back to the Curbsiders. I'm Dr. Matthew Frank Watto, here with my great friend and America's primary care physician, probably the primary care physician, Dr. Paul Nelson Williams. Hey, Paul.
Hey, Matt, you lean into more and more words with every introduction. How are you?
Yeah, I'm just riffing here, Paul, On tonight's show, we are going to get into some benign hematology. That's right. We're talking about thalassemia, some bleeding. We're talking about neutropenia. Paul, it's a great episode. And we have a great guest, Dr. Brad Beeler. And Paul, before we introduce our co-host and hear more about our guest, what is it that we do on Curbsiders, as if people don't know?
I mean, just in case they don't, if you're tuning in for the first time, folks, we are the internal medicine podcast. We use expert interviews to bring you clinical pearls and practice-changing knowledge. Matt, as you allude to, we are joined by a third co-host. We are joined by Wunderkind, super producer, physician extraordinaire, Dr. Paul Wirtz. Paul, how are you?
I'm doing great. Just happy to be back.
We are delighted to have you. And why don't I leave you the space to tell us a little bit more about our guest and maybe even touch on some of the things that we talked about.
I would love to. So we talked to Dr. Bradley Beeler. He currently serves as the program director for hematology and oncology at a large academic medical center in San Antonio, Texas. Dr. Beeler earned his undergraduate degree in biochemistry and molecular biology from the University of Tennessee. He attended medical school at East Tennessee State University and completed his internal medicine residency at the University of Florida. He then went on to complete fellowship training in hematology, oncology, and bone marrow transplant at SACHEC. In his current role, he splits time between practicing malignant hematology and transplant medicine and leading the fellowship program where he's deeply committed to training the next generation of hematologists and oncologists. Later this year, Dr. Beeler will return to East Tennessee State University as a faculty member, bringing things full circle for him. In this episode, he walks us through the approach to common benign hematology topics, including Duffy null-associated neutrophil count, bleeding disorders, and thalassemia. So without further ado, let's get to it.
A reminder that this and most episodes will be available for CME credit for all health professionals through VCU Health at curbsiders.vcuhealth.org. Brad, thank you for joining us. We've been talking for a little while here, but time to bring the audience in. And they want to know a hobby or interest that you have outside of medicine.
Well, thank you for having me, first and foremost. I think the most important hobby I have right now is probably being a glorified Uber driver for my kids. I'm meeting soccer games, basketball games, volleyball games, swim meets. I'm even thinking about putting a taxi meter in my car just to make it official. But typically what I'm doing is hanging out with my wife, hanging out with my family. We enjoy the outdoors. We enjoy what San Antonio has to offer. So spending time together is probably my biggest hobby.
Yeah. When I lived down there, there was a lot of wildlife, any run-ins with snakes, spiders, scorpions, things like that. I mean, that was always a favorite.
So the big thing for me is fire ants. I got to stay away from those things. So that's the biggest wildlife I care about.
Yeah.
I have so many allergies to insects and venom, so I stay away from those things. Fortunately, not too many run-ins with any snakes or anything like that. So
my wife stepped on a tarantula with a pair of rain boots because she was afraid. And then she found out that it was outside our house too. Then she found out that they're pretty much harmless. But yeah.
Oh, I would have lost it if I stepped on a tarantula with shoes on, with shoes out. It does not matter.
I think she put them on because she was afraid that it would be like we had young kids and she's like, I saw this thing, I have to kill it. So she put on like her most heavy duty shoes and stepped on it, and then my friend's like, oh, we used to have tarantulas all the time. Like my parents would like pick them up and stuff. They're harmless. And she's like, great.
She's probably legendary among tarantulas now.
Yeah, yeah.
Yeah, exactly.
I never saw a tarantula when I was down there, so I'm glad my wife had to deal with that.
Yeah, I haven't yet. I've got about a month left here in town, so hopefully I don't run into one, but, not on my bucket list before getting out of San Antonio, I'll tell you that.
Yeah. All right. Paul Williams, what would you like to ask, or do we need to get to a case?
I think I will ask about favorite failure this time around. That's always a question I like to hear the answer to.
So for me, it was really not getting accepted into medical school when I first applied. To me, at the time, it felt like a critical setback, and really, it really showed me the value of persistence and how there's a lot of uncertainties in medicine. And as I've gone through all stages of medicine, from medical student to resident to fellow to staff, there's so many uncertainties in medicine. There's so many things that sometimes you can't control, and I think not getting into medical school helped me sort of learn to navigate the uncertainties of medicine. And so I think the biggest failure I've had was probably not getting in, but I think it also turned out to be probably one that's sort of molded me and groomed me to be kind of where I am today, and understand that there will be setbacks, there will be obstacles, but I think that's why we all do what we do, is because we're here to help a patient, and there's going to be struggles along the way. And I think that kind of resilience, you don't just acquire. You have to learn through failures. I think that for me was the most important.
That's great. Thank you.
Well, Paul Wirtz, I think we should get to our first case because we're ambitious. So we might get to 4, we might get to 3, but we're going to try to get to 4 cases today. So let's do the first one.
Let's do it. Let's talk about Danny. So she's our 22-year-old African-American female who's referred to your hematology clinic for workup of neutropenia. The patient is asymptomatic, and the lab was drawn as part of a routine physical for some reason. Upon discovering neutrophil count of 1100 that has persisted on repeat, workup with HIV, ANA, and B12 folate was done and was unremarkable. So in general, what is your approach to patients suspected of having Duphenol-associated neutrophil count, which was previously known as benign ethnic neutropenia, and what can be done in primary care to avoid an unnecessary workup in these patients?
And are we calling this DANC now? Is this is DANC, D-A-N-C?
D-A-N-C, dance?
Yeah, that's what we're calling it now, and I think that's probably a move in the right direction, so to speak. So I think it's important to understand what type is. I think sometimes that's a little bit nebulous for medical students and maybe some interns and residents and even staff. So really, what it is it's a single nucleotide polymorphism, and it's in the ACKR1 gene. And so what this polymorphism does is it interferes with GATA1 transcription factor. And basically, what that ends up translating into is absence of really the Duffy antigen on the red blood cells. And for years, it's been termed this benign ethnic neutropenia, and it was, termed a condition when it's really not pathologic at all. So it's really kind of shaped us to change our framework of how we label these things. And so now I think the most appropriate thing to call it is dank. And this is very common in various ethnic groups. And so for African individuals, it's as prevalent as 68 to 100%, and in some Middle Eastern populations, it's as high as 53 to 97%. So it is quite common. It is fairly common, and really your European ancestry, it's typically less than 1%. So this is a common referral that we do get, and I think the biggest thing that you have to do is provide reassurance. Oftentimes, we have the luxury of having reviewed various CBCs in the past, and we can see that that count has been stable. Sometimes you don't necessarily get that luxury. So when I work up these patients, if I saw this patient in clinic, I would first assess for symptoms, right? So are you having any fevers? Are you having any weight loss? Have you had a history of fevers? Do you have a history of oral ulcerations, skin rashes, anything like that? And obviously taking a medication history into effect as well. But if you understand that, get a good family history, and understand that these patients may be from ethnic background that does predispose them to situations like this, I think a count of 1100, that's a normal neutrophil count for a lot of individuals. So I think the whole thing of calling this benign ethnic neutropenia And labeling this as a condition was probably predominantly in a white medical system where there was nothing wrong with these patients to begin with. And so I think it's important for really primary care physicians to really kind of lobby or look for new norms in terms of reference ranges for neutrophil counts based on a patient's background.
And I was reading about this that it does not appear that there's any, like, clinically it's not relevant. Like, there's no increased risk for infection that we can tell. And you can't I also read that you can't really, a patient's self-identified race or ethnicity doesn't necessarily tell you. So are you ever testing patients, like, to prove that they have this SNP? Is that worth doing in any cases? I mean, a lot of the times when I see this, like you said, you have a lot of prior CBCs, and you can just be like, your white cell count has always been 3.5. Like, I'm not worried about this.
Right. No. So definitely a good question. So neutrophil counts around 1,000 to 1,500. I don't have too much concerns about, provided they don't have a lot of infections, provided they don't have any constitutional symptoms. Those are things that I will just observe and really provide that patient reassurance. The ANC can drop to around 600 to 700. That is sometimes around the mean of certain cohorts of patients. I think if we look at all comers that have this dank neutropenia, I think the neutrophil count hovers around 1,000 to 1,200, but it's very common that patients can have neutrophil counts around 600 or 700. And I think one thing to be the most difficult job in medicine is a primary care physician, because you have to be able to provide reassurance to that patient and not really worry them that this is a condition that they have, that this is a pathology that warrants expert evaluation, when generally it does not. So, cases that are 1,000 to 1,500 asymptomatic, this has been documented. I'll observe those patients. They can follow up with their PCM. 500 to 1,000, you can you can certainly, if you have the clinical context of a patient that's been stable for many years, those patients opt for observation too. Now, you're not wrong to get sort of single gene testing, and we can certainly do that. And some of my partners in my practice do that, and that's completely acceptable. Um, but I think when we, as a program director, one thing that I teach my fellows and teach residents too is system-based practice and making sure that you're using your resources appropriately. The single nucleotide polymorphism single gene testing for the ACKR1 gene is about $695. And bone marrow biopsies are about $1,500 to $3,000. And, if you have a patient that's clinically stable, let's say they have an ANC of 700, this has been the case for the last decade. Let's say you have the luxury of looking at all those CBCs, and you decide, well, now's the time. I'm going to order this Duffy Knoll associated neutropenia SNP, the SNP that you had mentioned. And what are you going to do if it comes back negative, right? I mean, are you going to opt to do a bone marrow biopsy on that patient? I think you have to think about the implications of testings that you have. So in my practice, 500 to 1,000, I have the luxury of seeing those patients, and I have the luxury of reviewing their CBCs from the past. I'll typically observe those patients. You're certainly not wrong to get the SNP testing, the single gene testing. Um, Now, neutrophil counts less than 500 is a rare entity with dank or Duffy Knoll associated neutropenia. There, you can certainly get that testing, but I think you should think of another etiology if you're having ANCs that are typically below 500 in that case.
Yeah, and the other thing that I was just reading is that another reason this matters is patients might be excluded from trials if they have this lower neutrophil count, or certain, they might be less likely to receive, like, more aggressive chemotherapy treatments if they have a cancer. So I think that's a reason to talk about it and just to be aware that it exists.
No, 100% agree. When we look at clinical trials and protocols, there's a lot of patients that are excluded just for the fact that they have this Duffy associated neutropenia count. We're underrepresented by minorities in clinical trials. That's a fact. We know that. And I think that just further identifies some areas of systemic racism where we can probably improve upon how we manage patients, how we enroll in clinical trials, and ultimately how we treat these patients. I think that's a big deal. And one question that I'd sort of skipped over was these patients are not at an increased risk for infectious complications. And I think if you have that unique patient that's around 500 to 1,000 for their ANC and you want verification, getting the SNP is certainly not a bad idea. My practice is to not if they're clinically stable, but I do think you bring up a good point where a lot of these individuals are excluded from clinical trials. And that's I mean, you're talking about 65 to 100% of patients that have African inheritance, or 57 to 97% of patients that have Middle Eastern inheritance. That's a large population that we're really discounting for clinical trial participation.
Yeah, I have to say, if someone's riding with an ANC of 700, even if they feel like $1 million, I think I'd probably appreciate a hematologist just giving their benediction that I
No, agreed,
it's,
and
it's it,
no, I think
I'll
so.
defer fancy pants testing to them, but that's the type of patient where I might be sweating a little bit, and I'll let you say that I worry too much, probably.
No, 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 and I think that's appropriate, and the reasons that I would say a hematologist is warranted is any ANC under 1,000, I think, should be evaluated by a hematologist. I think anybody that has constitutional symptoms, if symptoms are progressive, if they're starting a medication for their autoimmune disease or their seizure disorder that may lower their ANC, I would never discount a referral from anyone that had an ANC less than 1,000. So, yes, I think patients that have an ANC less than 1,000, they deserve a hematologist to evaluate them.
All right. Wertz, anything else you want to get to on this topic, or should we go on to the next case?
No, I think we can move on. We can start talking about our friend Willie. He is a 24-year-old male. He presents to the primary care for a pre-op visit for wisdom tooth extraction. He was sent here by his dentist after disclosing that he has been suffering from repeated heavy nosebleeds, and his dentist also noted easy gum bleeding. So let's say this is the only information you have. How might you structure your interview, and are there any tools that primary care physicians can and should be using when they suspect a potential bleeding disorder?
I love these cases. I love patients I love cases. I don't love patients that have bleeding disorders. Don't That's not the case. But I love working through
You're
these
happy to
cases.
work with them.
Yes, I'm happy to work with them. So this is somebody that I look at, I get the question stem or I get the encounter and I'm thinking, okay, this patient's a bleeder, right? This is an oozer, this is a bruiser. Sort of my mind goes to this mucosal bleeding. Is this a primary hemostatic disorder? Or it doesn't sound like a secondary hemostatic disorder where it would be more hemarthrosis, things of that nature. Mucosal bleeding, primary hemostasis. I'm already considering the fact that it's a male. Is this something like von Willebrand's disease? How do we need to work through this? And so as a as a hematologist, I get these referral, and the one thing that I count on is that the internist or the primary care physician, family physician, what have you, has done the bleeding assessment tool. And so that's a you can get it on MedCalc. It's a calc you run through, but it takes into account things like personal bleeding history. So, do they have episode of epistaxis? Do they have bruising? Do they have prolonged bleeding after dental extractions? Do they have a family history of bleeding? I think it's important that this tool also takes into account medication histories, physical exams. Do you see easy bruising, large bruising, things like that? And then you really get this bleeding score, and it kind of tells you what is a typical bleeder versus what is an atypical bleeder. And so, really, adult males, if their bleeding score is over 4, then that would suggest that he's an atypical bleeder, and a female over 6 would suggest an atypical bleeder. And those patients need to be referred to a hematologist.
Brad, I'm ashamed to say I think I intuitively ask a lot of the questions you just mentioned, but I have not used the bleeding assessment tool. So tell me, like, how long does it take to administer it, and remind us a little bit about the scoring. You alluded to it, but I just haven't used it before.
Yeah, so the components of the test take into account personal bleeding history, family history, medication, things of that nature. And it's a fairly quick tool. It's on MedCalc or any kind of medical program that you have. You can calculate the scoring there. It takes really seconds to get that.
Oh, okay.
The longest part would be asking history from the patient. And really, this helps identify typical bleeders versus atypical bleeders. And really, an atypical bleeder in an adult male is 4 or more. So if you get a score on your calculator and it spits out a 4 or higher, then that's an atypical bleeder, and that prompts referral to a hematologist. A female, 6 and above would be considered an atypical bleeder in the female space, and that would also warrant evaluation. And those things do include, and I may not have mentioned to this, but also heavy menstrual cycles, things of that nature.
Yeah. And so Paul Williams is, I don't know, does this come up a lot for you? Like this, the bleeding assessment? I mean, I ask about this a lot, but I feel like I'm not referring a ton of people to hematology for bleeding.
Yeah, no, I think like you, a lot of the stuff I would like to think that I would ask most of these questions, though I don't think I had a specific, I wasn't using it in terms of specific test. It comes up. I feel like the patient coming in the office saying, "Yeah, I bruise fairly easily," or sometimes I get nosebleeds is a fairly common thing, but I've not used this as a quantifying. I don't know that I do a whole lot of referrals to hematology because at the end of the day, I feel like I can usually find an alternate explanation for a lot of it, or initial testing comes back stone cold normal.
Right, and I think that's an important factor. As me getting the referral, oftentimes I've assumed that this has been done, and by definition, by the time they get to us, they're at least an atypical bleeder because they're seeing a hematologist for said condition. So we do rely on that a good history is done, and as you guys know, I think 80% of the diagnosis certainly comes from historical questions that you ask the patient and what you find out from them. So I think it's a good tool. It's quick. It's easy, and I think it'll sort of streamline what's appropriate for a consultation to a hematologist.
Is there any testing you would want us to do ahead of time? I mean, I would probably order a CBC and a PTT, PT, INR, just to, and probably liver tests as well, chem panel. But anything else that you're wanting us to get before we send them over your way?
Yeah, no, I think those are complete and those are comprehensive. And I think that's as a primary care physician, I love when I see those testings done, right? I mean, I think if a patient's coming to me and they're telling me that they've had several courses of bleeding, heavy bleeding, I'll sometimes additionally say grab an iron panel because if somebody's bleeding as heavily as they say they are and they've never had a transfusion, they've never had iron deficiency, sometimes you have to really approach those cases maybe with a little bit of skepticism. But I think that's the only other testing I would do at the time. And you can garner so much information from a CBC. You can garner so much information from a PTT too. And I think I love when I see those because the PTT can tell you so much about what's going on, especially with mucocutaneous disorders.
Yeah. So what might like your thinking be like if we sent you somebody? What are you looking at in the labs, and what additional labs might you be getting at a first visit? If you see somebody and their bleeding assessment tool score is high, greater than 4 for a man, greater than 6 for a woman.
Yeah, so in those cases, looking at them, are they iron deficient? If they are, clearly they have some evidence of bleeding, right? Are their platelets low? Do they have thrombocytopenia? Is there a factor of a platelet adhesion that could be affected? And then the PTT, that's the real differentiator for me. And the PTT is a great test. And so basically, we get the blood from the patient, we separate it out from plasma and red blood cells, and then we add in partial thromboplastin along with kaolin to get the reaction started. And we just measure how long it takes for that plasma to clot. And that time should be 25 to 35 seconds. We'll add some calcium, some phospholipids in there. But anything that prolongs that PTT, it's either maybe there's a factor deficient present, maybe there's a factor inhibitor present. Something is awry there. And I think the PTT is a good assessment. And sort of my framework when I approach cases like this is this patient a bleeder or a non-bleeder, especially in the context of an elevated PTT. I think that's of critical importance. I'm a lumper and a splitter, so I see an elevated PTT, I think, are they a bleeder or a non-bleeder? And that helps sort of narrow down my differential in those cases. So if you got a bleeder, they've got a little bit of anemia, they have a microcytosis, let's say, and they have an iron deficiency, and they've had transfusions in the past, iron infusions in the past, and their PTT is elevated. And this patient's a clear bleeder and it's mucocutaneous. Your differential at that point is bleeders. There's six diagnostic possibilities it can be. And then you have your non-bleeders, a PTT that's elevated. This patient's never had a bleeding problem, had multiple surgeries, no bleeding problem. And then there's 6 entities they can be on that side of a non-bleeder. And so when I think about these cases, in our case here, this patient's got labs. Have we went over the labs yet? I'm sorry.
Yeah, let's Wirt, you want to read him? We have labs for this patient?
Yeah, we did get some labs back. They had a mild anemia, hemoglobin of 11.5. Platelets are normal at 245,000. Their INR is 1.1, and their PTT is just ever so slightly elevated at 43. So that's what we got back.
Gotcha. So this patient is a bleeder, and as mentioned, PTT is elevated. We have a bleeder. There's 6 diagnostic possibilities, and then in a non-bleeding patient, which is different from ours that we're evaluating here, there's 6 possible entities there. So for the bleeders, in a case like this, there's a couple of things I think of, and I think it's important to remember that clinical context always trumps, right? So PTT elevated. One of your differentials is this a factor 8 loss? Does this patient have hemophilia A? And that's where clinical context is important. Is this patient coming? Is it a male, right? So this is an X-linked related disorder. Do they have a history of hemarthrosis? Things like that. That would certainly prolong your PTT. That's not the clinical context we were given here. Hemophilia B, factor 9 deficiency, same type of scenario. Is this a male patient? Do they have hemarthrosis? Have they had a long, prolonged history of bleeding? That's not our patient in this particular context. And I think the one thing that is really helpful in these cases of PTT is you really need to determine if there's a factor deficiency present or if there's a factor inhibitor present. And the way I would do that as a hematologist, and I think this is fair game for internal medicine, family medicine, primary care doctors, is understanding what a mixing study is. To have a normal PTT, you really only have to have 30% of your factors present. And so if we mix, right? So we take control plasma, which is 100% plasma, patient plasma, which is unknown, and we mix those together. If we incubate that an hour and 2 hours, that PTT should now correct to 25, 35 seconds, right? And so if it does correct, you have a factor deficiency. So factor 8, factor 9, that's where clinical context is important. Is this a male? Does he have hemarthrosis? Those things. If it does not correct, you have to think that there's something inherently within the patient's plasma that's causing it not to correct. And that would be a factor 8 inhibitor, right? So an antibody to factor 8. And so that's the other differential item we think about in this particular scenario. And now, factor 8 inhibitors clinically typically happen postpartum females. There's a lot of inflammatory milieu. There's a lot of new antibody production being made. We see them in those contexts. But we also see them in older gentlemen generally that have a lymphoproliferative disorder. They make stupid lymphocytes and they make stupid antibodies. And these antibodies can make factor 8 inhibitors. And so those are the 3 things that we look at in those cases, right? So mixing study would be helpful to determine a factor deficiency or a factor inhibitor present. Now, this patient doesn't really fit the bill for a factor 8 inhibitor. It's a young male with mucocutaneous bleed, so it's a little bit different here. So those are 3 entities in the bleeder section. And the other one is usually done by grounds of history. I can't tell you the amount of times I've got a PTT consult for elevated PTT, and the patient's on Lovenox or heparin, something like that, right? History is always important. So make sure you rule out heparin. And so, you think about those, but those things do happen. Lovenox doesn't affect your PTT too much, but it certainly can have some mild elevation such as this. One of the hemophilias that can be a little bit heterogeneous, meaning they may bleed, they may not bleed, but they have a prolonged PTT would be hemophilia C, and that's a factor 11 deficiency. And so a mixing study would help you there too, because it would certainly correct. And the one that I think's most salient in this case would be von Willebrand disease. And so I think it's important to remember what von Willebrand factor is, right? So von Willebrand factor has no catalytic activity. It is not an enzyme. It's really a binding substance, if you want to think about it that way. It's a protein. One arm binds to the collagen on the subendothelial. The other arm binds to glycoprotein 1b on the platelets to make sure you have aggregation. That's one of its jobs. It has 3 very critical, important jobs. One, I just mentioned, platelet adhesion. 2, of critical importance, is it actually protects factor VIII. So von Willebrand factor protects factor VIII. And it does that in vivo and in vitro. If you have no von Willebrand factor, you will by definition have a factor VIII deficiency because it's degraded in seconds within the plasma without von Willebrand factor present. And the third critical role that von Willebrand factor has is angiogenesis. And a lot of people are like, that doesn't make sense to me. And I think the best explanation I can give for angiogenesis as it relates to von Willebrand factor is, have you guys heard of Hades syndrome? It's the aortic stenosis with the AVMs in the right side of the colon. And so von Willebrand factor is secreted in large multimers, and it's really involved in shear stress, right? So as you got shear stress through your aortic valve, if that's grossly stenotic, then you're going to bind up all of your von Willebrand factor, right? And so now this patient has low von Willebrand factor. They have really low levels of factor VIII. They have presented themselves as a bleeding diathesis, and now they have AVMs and angiodysplasia of the right side of their colon, and these things bleed. And you get a von Willebrand panel on them. The von Willebrand factor multimers, the large multimers are low. The factor VIII may be a little bit low. And how do you correct that patient? Well, you correct their aortic stenosis. Once you do that, von Willebrand factors normalize, factor VIII normalizes, the angiodysplasia and AVMs within the right side of the colon all just miraculously resolve. And so they have a critical role in angiogenesis. So in a patient like this with an elevated PTT, mucocutaneous bleeding, identifies as an oozer and bruiser, I'm kind of thinking that this patient may have von Willebrand disease. And I would not leave that up to you guys to get a mixing study. I would see this patient. I see the elevated PTT. I get the clinical history. His bleeding assessment tool identifies him as an atypical bleeder. The mixing study corrects. We do have a degree of a factor deficiency there. I have enough information now that I would get a von Willebrand panel, and that would include a factor VIII activity level. It would include a von Willebrand factor antigen, a von Willebrand factor activity level, and that's a ristocetin cofactor. And I would get multimers on this patient. And that's the way I would kind of work this patient up. And playing odds, this is probably a type 1 von Willebrand disease, which makes up about 75 to 80% of von Willebrand disease cases that we see.
I ordered the ristocetin cofactor activity just as a matter of course for all of my new patients, just to be on the safe side. So I'm glad to finally know what to do with it.
Yeah, exactly.
That's along with a Lyme panel, red blood cell folate. Right, what else, Paul?
Right,
for sure.
Exactly.
It just popped up one day. I'm like, yeah, let's just see what happens. And so far, so good.
Get those and procalcitonins on everybody. And
yes, absolutely.
I think I wouldn't be a complete if I didn't tell you the differential for PTTs, elevated PTTs and non-bleeders. And if that's okay, we'll just complete out that little diagram there. Yeah. And so when I see a non-bleeder with an elevated PTT, the mixing study is helpful. As mentioned, make sure this patient's not on heparin. I'll get calls from the inpatient ward like, hey, this guy's PTT is 120. I don't know what's going on. And I'm like, well, you may want to take him off the heparin infusion if he's bleeding. Just understand those things. But heparin can do it. So think about drugs. Hemophilia C, remember that can be a heterogeneous presentation. They can be bleeders. They can be non-bleeders. And let's say you do the mixing study on a non-bleeder and it does not correct, but this patient is a historical non-bleeder. In fact, this patient has had clots. This patient has had multiple miscarriages. Then you should be thinking about things like antiphospholipid syndrome, right? And so those are the things that you consider in those cases. I remember going through the last three are kind of all similar, but I remember going through med school and I thought all I had to ever learn was the intrinsic pathway and the extrinsic pathway, and that was it. I'd be good. Turns out that you need to know the common pathway, but there's also a thing called the contact pathway. I never learned this in med school. And so really the contact pathway primes the intrinsic pathway. And the way that works is prekallikrein is activated by it's a zymogen, so it's not active until it's catalytically cleaved. So prekallikrein goes to kallikrein by mechanism of high molecular weight kinagen. And if you're deficient on prekallikrein or high molecular weight kinagen, you can have a very prolonged PTT. That's only artifactual. And the way that process works is prekallikrein is activated by high molecular weight kinagen, and then that takes prekallikrein to kallikrein. Kallikrein prime is factor 12 and pseudo activates it, and that's how the intrinsic pathway starts. So the only other time you can have a prolonged PTT in a non-bleeder is if they have a deficiency of prekallikrein, high molecular weight kinagen, or factor 12. And the tip off for that is typically your PTT is actually greater than 100. And so we'll get these cases sometimes of a patient that has biliary dyskinesia and he's had it for a year and he's going for surgery. Finally, a surgeon has agreed to take him to the operating room and anesthesia gets some pre-op labs. His PTT comes back 110 and you get the workup and the surgeon's like, what do we do? How do we go about this? You get history from the patient, never bled, multiple surgeries in the past. You get a mixing study. That mixing study corrects. That's a very prolonged PTT to correct with mixing. So already, if it's over 100, you're thinking this has to be a contact pathway deficiency. And then if the mixing study corrects, I'll give you free rein to order whatever factor levels you want to order at that point. I don't want to shotgun all of them, but I'm already thinking this is probably the contact pathway. And we actually have LabCorp, I think, has a contact pathway specimen that includes prekallikrein, high molecular weight kinagen, factor 12, and factor 11. And we'll get those back, and they'll be prekallikrein deficient or factor 12 deficient. And the surgeon says, well, his PTT is 110. I'm not taking him to surgery. And you're like, no. There's actually a signal these patients may clot more than bleed. So you may want to make sure you give them proper anticoagulation for prophylaxis, So it's always an interesting story. But that's your differential for prolonged PTT. Lump them into and split them into bleeders and non-bleeders and work through that differential. I think that's a sort of a helpful clinical pearl that's helped me as a hematologist.
Okay, so we'll definitely have those listed out in the show notes for people, because I'm sure it's hard just hearing the audio to remember all of those, but the thinking through it like that makes a lot of sense. We're thinking about have people been exposed to heparin? Is there a deficiency or an inhibitor of a certain factor, and or do they have von Willebrands if they're bleeding?
Yeah.
And then for the non-bleeding side, we think about factors again, right? But you also said we think about the antiphospholipid syndrome, and then this contact pathway stuff.
Contact pathway stuff.
Yeah.
That apparently nobody learned about that in med school. I don't know.
I did not. I think this might be the first. I mean, I've heard of some of those factors you were saying, but I don't. I'm not thinking of talking about contact pathway. I know intrinsic and extrinsic, and I probably couldn't tell you I don't remember them anymore exactly.
I remember those are the types of things where I heard them I've never heard of this before, so therefore I will never need to actually learn it for anything in practicality. And it turns out that was not correct.
Yeah, exactly.
For the audience, so if we're thinking about von Willebrands, because I have sent this off before, I have sent off some of the testing, but you mentioned 3 tests that you like for von Willebrand. So it's the antigen, the aristocetin cofactor assay or activity, and then the multimer analysis. Those are the 3 that you like to get.
And to include factor 8 activity levels on
and
there
a factor
too.
8 activity.
Sure.
Okay.
Yeah.
Right.
And I think that's the big, when I talk about von Willebrand factor, the importance that it has, platelet adhesion for sure, right? And then the other thing would be protection of factor 8. If you have low von Willebrand factor, you will have low factor 8 levels. And that's why the PTT is prolonged in these cases.
Got it.
And that's why it corrects with the mixing study.
Okay.
So first, I just want to mention for our CME overlords that Lovenox is an enoxaparin, and obviously we don't have a preference for your personal anticoagulation choices. But I guess around this question, Brad, these patients will often have the diagnosis when they come to us. So I'm seeing someone in the primary care office who has, von Willebrand's in their problem list. What type of counseling should I be giving around things like, say, pregnancy or an elective surgery in terms of what they should be mindful of, what treatment they might need. Do they need to be anticoagulated? What general counseling tips should we have in the primary care office, or at least be familiar with?
Yeah, so good question. I think the counseling is quite nuanced because it is a chronic disorder that they will live with, right? And there's what complicates the thing on von Willebrand's disease is there's most of the time 80%, 75 to 80% of the time it'll be type 1 von Willebrand disease, which we see most commonly. There are type 1 is a quantitative deficit. Type 3 is absence of completely, and type 2 is really a qualitative deficit. Most of cases are hereditary in terms of their autosomal dominant. I like to term the phrase autosomal codominance with these because when you think about autosomal dominance, right, it just takes one gene to have an abnormality. And that's in fact what type 1 is, right? If both genes are abnormal, that's what type 3 is. So I always think of these as autosomal dominant. So there's a 50% chance that those genes will be passed down to your offspring. Type 2 is qualitative. And there are various different severity, forms of severity of each of those subtypes. And, patients that have type 3 von Willebrand's disease, meaning none, that counseling is a little bit more difficult. Those patients need prophylaxis. They'll need to be on von Willebrand factor concentrates, and they'll need to be monitored throughout pregnancy. And those patients have a high risk of bleeding complications. Similarly, there's a type 2N that is very similar. And the way I remember von Willebrand type 2N, and this may be outside of the scope for primary care, but N is type 2 Normandy. Normandy has 8 letters. And I remember that type 2N means there's a polymorphism within von Willebrand factor that enables it from binding to factor 8. These patients have no protection for factor 8. They almost behave like a hemophilia A patient. And so their counseling is a little bit more nuanced. But what you're going to see the most is going to be these type 1 von Willebrand's disease that have some, but the good news for pregnancy is most of those levels, as estrogen increases during your pregnancy, your von Willebrand factor, your factor 8 levels increase with pregnancy. So I don't worry too much for type 1 von Willebrand disease patients in terms of prenatal bleeding or pregnancy related bleeding in and of itself. Certainly, you have to make sure that the patient, if you're going to do, I think it's important if they're getting neural axial anesthesia, if they're getting an epidural, a hematologist and anesthesiologist need to be involved. They need to make sure that these patients have adequate von Willebrand factor levels, ristocetin cofactor activity. Those numbers should be between 50 and 150 before any kind of procedure such as that. The thing that I worry about is a pregnant patient that has a baby, estrogen levels, the von Willebrand disease, the von Willebrand factor increases, factor 8 increases. At about day 3 or 4 after the placenta is delivered, estrogen plummets. There for about day 4 to several weeks after that, with a median time of about day 15. Those von Willebrand factor will nadir, and patients may actually have some hemorrhagic complications from vaginal blood loss. Most of the time as a hematologist that I'm consulted on vaginal blood loss in the context of a pregnant patient or a patient that just delivered is usually uterine atony. And that's not the case at this time period. 15 days out shouldn't be an issue. This is something that we'll have to counsel patients on to seek hematologist care to make sure that those von Willebrand factors stay level or stay appropriate in terms of what levels they should be at. But the counseling involves making sure that they know what bleeding symptoms to look for. Most of my patients that have von Willebrand disease have a prescription for Amicar or TXA. Amicar is aminocaproic acid and tranexamic acid. Those are antifibrinolytics. So these are good for like dental bleeds, mucocutaneous bleeds. They can take these during the time that they have maybe a bleeding symptom to stave off something that can truly turn hemorrhagic. Um, Other things that we have to counsel for is, you know, it's important to know that von Willebrand disease doesn't really protect you against blood clots. There is a signal that they may protect against arterial clots, and part of that is because the von Willebrand factor itself is really involved in shear stress, and that's when those multimers, they're those endothelial cells that line the blood vessels, the heart, all those things. There's these little storage organelles called Weeble Palad bodies, if you guys remember those.
No.
And they've got
Nope.
they they've got all these little, like a slinky, these von Willebrand factor multimers are packed in. And once that endothelial is injured from inflammation or what have you, those von Willebrand factors pull out like a slinky, and that Adams T13 will cleave them in the smaller places. And if you have an absence of that, you're less likely to have thrombotic complications from an arterial event. So there is a signal that patients may be protected from arterial clots, but there really is no protection against venous clots, so to say. So what happens if you have a patient that has a blood clot that has von Willebrand disease? With von Willebrand disease, there was a retrospective study that looked at blood clots in patients that have von Willebrand disease, and they identified 33 blood clots in this cohort of patients. Understandably, these are underreported. A lot of the products that we use for repletion of von Willebrand factor are crude factor, meaning these are pulled products, and these usually include factor 8 and von Willebrand factor. And most community hospitals have that. The von Willebrand factor concentrate is more costly, and a lot of community hospitals do not have that. So a lot of individuals will treat patients with von Willebrand disease with a combination of factor 8 and von Willebrand factor. You got to be mindful that it'll increase your factor 8 level, and anytime that factor 8 level goes above 150%, that does increase your risk for clots. So in that cohort of patients, 26 of those patients out of the 33 were really iatrogenic. They got the blood clot because they really got too much factor 8. But what you do? You should monitor those patients in the acute setting daily, monitoring factor 8 levels, monitoring von Willebrand factor levels, and want to keep the activity level and all of that between 50 and 150. And you monitor those for 3 months, and you can usually safely stop anticoagulation at that point. We still recommend giving dual antiplatelet therapy for those patients. The benefit there is that usually there is some protection against that. So the counseling can be quite nuanced, but it's a chronic disease that folks have to manage. You can get a long way with antifibrinolytics. Those are actually recommended for heavy menstrual-related bleeding. Outside of that, you can do some uh, progestin derived OCPs that can be helpful.
Yeah, and so I want to make sure I'm following here. So to wrap up this, because I want to get to our next case. But for von Willebrand, so we're saying that the patients coming in with acute bleeding might be getting this. They might be getting this crude mix of von Willebrand factor and factor 8, or if there's the more expensive product is available, it's von Willebrand factor concentrate, and if they're using that crude product with the factor 8, we just have to be careful that we're not giving too much factor 8, which can precipitate clotting.
Right, and it's a rare instance, but it does happen.
Okay. And then if these patients have to go on anticoagulation for, if they were to have a blood clot or a heart attack or something, they can still take dual antiplatelet therapy or anticoagulation, but they might also need periodic treatment with these concentrates, like the von Willebrand factor or the factor 8
Yeah,
concentrate.
yeah, it's exactly right. In the acute setting, I'll monitor that daily. On the outpatient setting, that's typically done weekly. If they're clinically stable, maybe every 2 weeks. And that's probably about as far out
Wow.
as I would test those patients. And a lot of that's very heterogeneous because some patients are severely infected and they have very severe von Willebrand disease. And clinical gestalt should always trump lab work. So if you're having issues with keeping the von Willebrand factor at a certain level at 50, right, despite concentrates, then I think that you have enough ammunition to come off of those if you feel like it's unsafe for the patient.
Okay. Let's get to our next case. And Wirtz, would you read this for us?
Absolutely. So we got Thalassemia. She's a 38-year-old Vietnamese woman who is referred to for chronic iron deficiency anemia. Review of her record shows her first CBC was drawn at the age of 25 and showed a hemoglobin of 9.8, a red blood cell count of 4.8 million per microliter, an MCV of 57, a ferritin of 48, a TSAT of 23. She's had a hemoglobin in the high 9s to low 10s for over a decade, with MCVs consistently in the low to mid 60s. She's been told she has iron deficiency anemia despite a normal ferritin, and over the years, she's received multiple courses of oral iron, at least 2 IV iron infusions, and even 2 blood transfusions during her last pregnancy. 2 years ago, she underwent a hysterectomy for obstetric complications, and as a result of her persistent iron deficiency anemia, has undergone 2 bidirectional endoscopic evaluations without any findings. She has been taking iron pills 3 times a day for many years. She's got insides of steel. She now has a hemoglobin of 10.3, an MCV of 64, red blood cells of 5.4 million per microliter, and a ferritin of 309, TSAT of 49. Her hemoglobin electrophoresis is normal, and her primary care provider was considering another iron transfusion. So, what is your approach to a chronic microcytic anemia in a case like this? And what are the screening caveats that we need to be aware of when we're trying to make a diagnosis of thalassemia?
Yeah, thank you, Paul. Good question. So, we this is a pretty common referral. So, I keep things easy with microcytosis. I'm a pretty simple-minded guy, and so I'm from East Tennessee, and in East Tennessee, we salt everything. We salt our roads, most of our foods, and even our anemias, I guess you could say. But I use the mnemonic eye salt. So that's my differential for chronic microcytosis. So I have iron deficiency anemia, that's the I. S is for sideroblastic anemia. And I will say that iron deficiency anemia is the most common thing that we will see, right? Sideroblastic anemia it's a rare entity, and I think of things like MDS with this. It's really putting iron in the incorrect places. Medication history is sometimes important. Is the patient on things like isoniazid, things like that? Um, but sideroblastic anemia is rare. Anemia of chronic disease, and I think it's important to remember that you have adequate iron, but you're just not putting it in the right places. And anemia of chronic disease now, a majority of those cases can be normocytic, but it also can present as a microcytic anemia. Lead poisoning, which I don't see too much in the adult realm, but it's certainly a positive thing that you can look at and think about, especially if you look at a blood smear and you see basophilic stippling, something like that. Get a good history, neurological symptoms, things like that, and thalassemias, right? So thalassemias are something that we see a lot, so that kind of goes well into the mnemonic eye salt. In this patient, you look at that, her ferritin's normal, it's iron replete, but she has a profound microcytosis. I think, one of the patterns that I've learned to recognize over the years that I see with thalassemias is really a patient that has an anemia, a mild anemia maybe, they have a microcytosis, but they have an elevated RBC number. That's typically a pathognomonic thing that I look at when I see a thalassemia, because iron deficiency should not cause an elevated RBC number. And what this RBC number is just ineffective erythropoiesis, right? You're making a ton of red blood cells. Your marrow is trying to keep up and keep up and keep up, but you're just not making adequate. These things get destroyed and hemolyzed fairly quickly. And so thalassemia, and I think that's a good kind of pearl to look at as a primary care physician. You have that pattern. Think about those findings. It's not clearly iron deficiency based on the studies that you get. Then you should do the next step and really look at getting a hemoglobin electrophoresis in those cases.
Yeah. And we talked about the Metzer index recently. I think that's the MCV divided by the red blood cell count. And so the thalassemia, you make a lot of little cells, right? And if it was iron
Right, exactly.
deficiency, you make fewer cells. They're small, but there's fewer of them. Was the way that it was
Exactly.
explained to
Exactly.
us. So,
Right. It's exactly right.
okay. So, yeah, I feel like this primary care physician, clearly this wasn't Dr. Paul Williams, who would have, I mean, certainly he would have repeated the labs a couple times because that's the Paul Williams method. But
Yep.
I don't think he would have overloaded this person with iron, which I think we're in danger of doing here. So I think most primary care doctors hopefully would have backed off of the iron, at least not been dosing it 3 times a day at this point.
Right. I mean, is that even recommended anymore? I think.
No, no.
Okay.
Yeah, on this show, I mean, for years now, I would say we've been recommending
Like every other day?
Every other day, or maybe once a day. I think some people argue maybe you get a little bit more iron if you take it every day, but a lot of people can't tolerate it. So the patients just take it every other day for the most part. So let's talk about with this thalassemia situation, and we're doing hemoglobin electrophoresis. We gave you a situation here where the patient, it was normal. So how is it normal in thalassemia, or how would you explain this to a trainee working with you?
Yeah, exactly. So, for when we think about thalassemias, these are to make hemoglobin, right? You have hemoglobin A, hemoglobin A2, and shouldn't have any hemoglobin F. I I say you shouldn't have any. Some people do have some hemoglobin F, but generally speaking, it's less than 1%. Hemoglobin A should make up about 97% of your hemoglobin. And about 2.5% should make up hemoglobin A2 and, less than 1% hemoglobin F. And hemoglobin A is really just two alpha globin chains and two beta globin chains. Hemoglobin A2 is two alpha chains and two delta chains. And really, we're fortunate enough to have on in terms of inheritance, we get four, should get four normal alpha globin chains. So chromosome 16 has two alpha chains on it. And so you get one from mom, you get one from dad. So you should have at any moment in time really four chains in a patient that is not impacted with thalassemia or some kind of hemoglobinopathy. And then you just have two beta chains. And so the important thing is that with you're not going to pick up alpha thalassemia on a hemoglobin electrophoresis unless it's one of the severe phenotypes. And right, so since you only have to have two alpha chains to make the hemoglobin electrophoresis or make normal hemoglobin, really, there is a scenario called hemoglobin H disease, where it's only one alpha chain that you have, and you end up producing mostly beta chains that will precipitate on a hemoglobin electrophoresis. And then if you don't make any alpha chains, that would be called like a BARTS, and that's hydrops fetalis. You would absolutely pick that up because it's all gamma chains on a hemoglobin electrophoresis. The point is that in those cases, it's pretty extreme, but you will not typically pick up alpha thalassemia on a hemoglobin electrophoresis. You will pick up a beta thalassemia, and that will be evidenced by usually a higher hemoglobin A2, maybe a little bit lower of the hemoglobin A. In some severe cases of thalassemia, beta thalassemia, you may not have any A because you're not making any beta chains. Um, so in a case like this, you look at the patient, you see a normal hemoglobin electrophoresis, that pattern that we had discussed with an anemia, a microcytosis, and a pretty severe microcytosis with an elevated RBC number and a normal hemoglobin electrophoresis, you're already thinking alpha thalassemia. The smear may be characteristic, so you look at a blood smear. I think it's always important to counsel trainees that if you're looking at a blood smear, know what you're looking for. If you're looking for thalassemia, you're going to be looking for target cells, things like that. So look for those on there. Then that to me is enough to consider, especially if you have an individual from the Mediterranean, Africa, Southeast Asia, something like that, to be pretty consistent with alpha thalassemia. You certainly can get the alpha thalassemia genes. Now that testing is about $900, and it only picks up about 90% of alpha thalassemia. So there is a high degree of negative testing with those, or false, I guess, positive testing in those cases. It comes back with four intact alpha chains. Now, what do? You can't really explain that anemia. So I don't get genetic testing in those cases unless the patient is impacted with a severe anemia, and if I'm concerned that there may be some prenatal counseling that needs to go into consideration. And so for a trainee, I'll explain as much as I can about how globin chains sort of create this four or this tetramer and surrounded by heme moiety. For patients, it's a little bit different. I basically describe it as cars. Is you're still able to make cars, they're just not, super effective at delivering oxygen where they need to be. And sometimes you just need to make more to compensate for that. And all the patients in my practice that have thalassemia, folic acid is always something that we supplement. I will tell you that there is a lot of patients with microcytosis that a lot of individuals, or not a lot, but some individuals don't take that next step, and they'll put them on iron thinking this will fix them. And patients have been on the iron for a year or two now, and we get their ferritin back and it's 1,000, and we're talking about maybe considering phlebotomy, which is a challenging concept in a patient that has maybe a baseline anemia. And then you're considering things like chelation, stuff like that.
And you mentioned the supplementing folic acid. Is there a specific dose you recommend, and does that change the hemoglobin typically? Is that going to raise the hemoglobin?
It usually doesn't raise the hemoglobin. It's a B vitamin. It's fairly safe. Standardly for just like if it's a thalassemia minor, maybe 1 milligram a day. And severe patients or severe thalassemia patients, I'll usually give them 2 milligrams or even 5 milligrams for some patients. A lot of people have some nausea with a higher dosing at 5 milligrams, though.
And these are people with more severe thalassemias, from what I understand. They're largely diagnosed in childhood, right? Like it usually presents earlier. You wouldn't be
Yeah.
catching this in like a 40-year-old or somebody coming in your office with a mild anemia.
Correct, exactly, and that's normally the case that we see these cases. I think it's important to remember that I think the primary care doctors have just as an important role as anyone in the case of a thalassemia patient, because when you think about the sequela of situations that these patients run into, is you got to think that their marrow is in overdrive to make out these red blood cells because their body is trying to stay oxygenated, their bone marrow is revving up, the marrow space becomes expanded. They get cortical thinning within their bone, and they have high risk for osteoporotic fractures, right? And so it's always important to screen these folks early for osteoporosis. And think about iron overload syndromes that can happen. Iron loves to deposit in the liver. It loves to deposit in the myocardium. It loves to deposit in gonads. And, there's all kinds of endocrinopathies that can develop because of those. And I think you have to be diligent about screening in terms of some of these conditions. You have to be diligent on screening for osteoporosis. You have to think about things like cholecystectomy in some of these cases. They may have some high turnover. There's a lot of bilirubin that gets, trapped within the gallbladder space. They're going to get transfusions. You have to be diligent about making sure they're vaccinated for hepatitis, those things. So I think it's very nuanced, but I think it really requires multidisciplinary care from a hematologist and a good primary care physician.
And with the more minor cases, the minor alpha or beta thalassemia, that are not receiving a lot of transfusions, are those concerns like the iron overload? Is that still there?
Yeah, I still have concern for those patients, and mostly because somewhere along the way, somebody has told them they have a microcytosis, they take iron. You still have to be diligent. Those patients do have higher iron stores, they have higher turnover. They are going to have a degree of hemolysis. Now, some patients that have alpha, silent carrier of alpha thalassemia, they're they're more, they're not impacted. Their prognostic is not adjusted. I don't feel strongly that they need to be on anything. But these patients that do have anemia, that do have high cell turnover, I think those are the patients that you have to be concerned about.
Yeah.
Brad, I feel like the what I would see, I'd like to think I'm competent enough as a primary care doctor. I would see a microcytosis, I would see a normal ferritin, and I would probably order the hemoglobin electrophoresis and maybe even diagnose a couple of beta thalassemia minors. And I guess other than patting myself on the back and adding a problem to the problem list, is there anything else for me to do there? If the patient, like if this almost always happens in the context of kind of wonky labs that are not alarming. They're just, I can't explain a couple things on the CBC. And then I make the diagnosis that way. But is there anything other workup that is warranted here? Anything else I should do? Any counseling I should do to talk to the patients once they actually have this sort of new diagnosis that they didn't feel until I do
No,
the laboratory
exactly.
workup.
Good question. And I think it's a proper to just provide reassurance to those patients. They're going to do well. They're going to be well, right? I think I probably just recommend folic acid in a case like that, maybe 1 milligram once a day if they remember things like that, you know. But I do think that providing those patients with a reassurance, because, you know, having them to there's a condition that I can't do anything about. What do I need to do? Like, I think just reassurance that they're going to do well and they're long-term survival is not going to be impacted from this. The one caveat I would say to that is I think it's very important that cases such as these, especially with these beta thalassemias, you know, so not all beta thalassemias are the same. When we classify beta thalassemias for years, it was, you know, beta thalassemia minor, beta thalassemia intermediate, and beta thalassemia major. We're sort of getting away from that and we're doing more of a transfusional dependent versus non-transfusional dependent. But I think for cases of beta thalassemia and then alpha thalassemias that do have an association with anemia, I think prenatal counseling is important. And I think as a primary care doctor, getting those folks in the right place to do so. You know, I think a lot of times with alpha thalassemia, especially from an individual that is identifies as being from like Southeast Asia, those patients have what we call a high risk for cis alpha thalassemia. And so the way I like to think about it, chromosome 16 has two alpha genes on it, right? And one parent may have completely lost that alpha thalassemia. So there's a chance that if they have a child with another individual from the same demographic area, they could be at an increased risk because they make no alpha globin chains. They could be a risk for hydrops fetalis or even hemoglobin H disease. And I think that's where the counseling would become most prudent is prenatal counseling for these patients in the preconception phase. So understanding that, I think that's the biggest benefit you could provide those. I don't feel strongly that these patients should be early screened for osteoporosis or anything like that, provided that's the only ailment that they have. Not even an ailment, that's the only thing that they have on their labs, right?
And thalassemia, like this minor anemia, is a common thing we see on the complete blood count. We see all sorts of things on blood counts tonight. We've talked about low white count. We've talked about anemia. What on the CBC, in your mind, this is your chance to speak to a lot of primary care doctors, should prompt us to be worried and send somebody to hematology?
Well, I think the thing that would get me the most excited and concerned would be like a blast, right? Hopefully, you don't see many of those on the outpatient side, right? So, um, anything like that. So, I think it's important to look at the differential and, you know, outside of the basic things. I think looking for things like blast, other cells, right? And I think it's important as a primary care doctor to when you look for a blood smear, know what you're looking for. I hear all the time from interns and residents, like, let's get a blood smear. And I'm like, okay, that sounds good. What are you looking for? They're like, I don't know, just weird stuff. And I'm like, well, that doesn't that doesn't help, right? And what you're looking for is dysplastic findings, and those are things that are difficult to describe. So, you know, if you look at the neutrophils, and those should be 3 to 4 lobes. If they're hypolobated, if they have 2 lobes, if they have 6 lobes, and it's not related to B12 or folate deficiency. If those neutrophils are hypogranular, those are the dysplastic things I'm talking about. But certainly seeing things like blast, if you see a cytopenia that you can't explain, that deserves a hematologist to evaluate. So if you have a single cytopenia that's not explained, say it's anemia, it's not explained by iron deficiency, it's not explained by B12 or folate, things like that. You know, if you can't explain it, those things need to be deserved. Certainly a bicytopenia. So if you have 2 cell lineages that are low, those things need to be evaluated by a hematologist. And those are the things that I would you know, look at as a hematologist, say, okay, this individual has done their due diligence. This patient needs a workup. This patient may need a bone marrow biopsy, things like that. Um, but those are the big things that come to
Yeah,
mind.
I can live with that. I mean, that's
Yeah,
Yes, that seems fair.
yeah.
yeah. I mean, if you like, I don't like MCHC, like, you know, I think about
I vote we remove those Paul Williams, is there a Doge for CBCs? I think we
Oh,
should.
God
I
forbid.
think we should be more efficient with our CBCs and just take the MCH, the MCHC off there, and that might save us all a lot of headaches.
Sure. If we're going to follow Doge principles, we'd remove the platelets and then put them back for the cost that is more than it was to take them off in the first place.
Yeah, exactly. The only thing those are really great for is agglutination. You may see an elevated MCHC or hereditary spherocytosis. Outside of that, I mean, I don't know.
Yeah. Yeah, I think we could.
Get
I think
rid
we
of.
could downsize some of our labs. Like we get, I'll have patients. They'll pick out their. I saw this one indice that was just slightly off, and I'm just like, all right, let's not worry about that. That's
Yeah, exactly.
I look at these labs all day. It didn't pique my interest. Well, we're gonna ignore it. Yeah.
Right, exactly. Like the MPV's a little bit low today. I don't know.
Yes.
Like, what do we do with that?
Yes, that's another one. That one out of here. Well, all right. Paul Williams has a chainsaw that he's going to take to the CBC for us.
Sure.
Okay.
Don't sign me up for this.
All right. Well, we've really enjoyed this, Brad, and I know we have so much more stuff that we could get to, but I think we got a lot of great pearls. We should stop here for now, and we'll need to do a part 2 at some point to get to more of these benign hematology pearls. So what out of what we talked about tonight, which was we talked about Duffy null, we talked about bleeding, like von Willebrand's factor, we talked about thalassemia. What would you like the audience to remember, like just a couple key pearls?
Yeah, I think from each case, I think understanding that all neutropenia is not pathologic. Understand that, right? And I think trying to get away from situations where there may be some systemic bias in terms of the way we label things as benign ethnic neutropenia. Those things shouldn't be necessarily used or taught anymore. I think that's a big thing. Understanding what pathologic neutropenia is, right? In the case of an asymptomatic patient, a relatively normal ANC, and I say normal, above 1,000, right? I think those patients can be observed, provided they're asymptomatic. In terms of a bleeding patient, I think it's important to know that you do have access to the bleeding assessment tool. It's a quick thing that you can look at and do. And the good news is you guys are already doing this anyway, right? And so I think just quantifying that within that framework will help you kind of understand which patients warrant hematology evaluation. And I think in a bleeding patient, it's always great to get coags, specifically PTT. I do think it's important to know an elevated PTT. That's where a hematologist makes their money. I think if you can lump those patients into bleeders and non-bleeders, and understanding that differential that we talked about can be helpful and help narrow down what these cases involve. And then sort of for our last case with thalassemias, I think it's critical to really, if I'm just getting into medicine as an intern, looking at these cases and seeing a microcytosis, maybe severe, a mild anemia, but an elevated RBC number, I think you know, always get the iron studies, but I think understanding that that may be a typical pattern that you see with thalassemia. And then looking at how a primary care can really impact those patients for osteoporosis screening, cardiomyopathy screening, things like that, iron overload, stuff like that. I think those are important critical factors that sort of can make harmony between a hematologist and a primary care physician in trying to treat these patients for the best available data and the best available treatment that we have.
Okay, and lastly, anything you would like to plug?
Gosh, I don't know. I don't have anything to plug really. Gosh.
Okay.
No, I'm boring.
That's okay. That's all right. All right, we'll check out your kids' basketball game if we're down in San Antonio sometime.
This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy.
Great, I guess. Still hungry for more? Join our Patreon and get all of our episodes ad-free, plus twice monthly bonus episodes at patreon.com/Curbsiders. You can find our show notes at thecurbsiders.com and sign up for our mailing list to get our weekly show notes in your inbox. This includes our Curbsiders Digest, which recaps the latest practice-changing articles, guidelines, and news in internal medicine.
And we're committed to high-value, practice-changing knowledge, and we want your feedback, so email us at askcurbsiders@gmail.com. A reminder that this and most episodes are available for CME through VCU Health at curbsiders.vcuhealth.org. Special thanks to our writer and producer for this episode, Dr. Paul Wirtz, and to our whole team. Our technical production is done by Podpace. Elizabeth Proto does our social media. Jen Watto runs our Patreon. Chris the Chew Man Chew moderates our Discord. Stuart Brigham composed our theme music. And with all that, until next time, I've been Dr. Matthew Frank Watto.
I've been Dr. Paul Wirtz.
And as always, I remain Dr. Paul Nelson Williams. Thank you and goodbye.